So yeah, in the previous class we had discussed about inflammatory bowel disease, in that mainly ulcerative colitis and Crohn's disease, right? So in this class we are going to study the management of those two diseases, that is ulcerative colitis and Crohn's. Basically, first we will in general study about the drugs which are used for inflammatory bowel disease. Okay, this can be used for both ulcerative colitis and Crohn's disease. The way and the combination we use it differ for ulcerative colitis and Crohn's disease, that we will study today. Okay, the first one being 5 amino salicylic acid agents. Okay, 5 ASA, amino salicylic acid agents. Okay, this is the mainstay of therapy in case of ulcerative colitis and Crohn's disease. Okay, what is the mechanism of action? How does this drugs or 5-ASA agents act? These agents basically inhibit nuclear factor kappa beta activation. So basically, what's happening in these diseases? There is inflammation continuously, right? So this inflammation is because of this factor activation. So if we inhibit this factor, there will be reduced inflammation and hence disease will be treated. So whatever the factors are there which are responsible for inflammation, that should be inhibited, and one such factor is NF kappa beta. Okay, so if we these 5-ASA agents inhibit these drug activation, if they are not active, there will be no inflammation, hence treated. Okay, similarly prostaglandins, these also are inflammatory mediators. So if we inhibit these prostaglandin synthesis, then there will be reduced inflammation. Similarly, free radicals, this will again these free radicals will again damage the cell membrane and everything. Okay, cell membrane damage will mainly free radicals will be there. So this free radicals scavenging should be done, and these 5-ASA, that is amino salicylic acid, will act by these three mechanisms, thereby leading to inhibition of inflammation. Okay, up to 80% of the unformulated acquired 5-ASA whichever we use unformulated, that is usually absorbed at proximal small intestine, that is duodenum or jejunum. Okay, and this will not reach distal small intestine or colon. So over the years we have modified this drug in such a way that it will reach distal small intestine and colon. How can we do that? By adding carriers, that is these 5-ASA agents are attached with carriers like sulfasalazine, olsalazine or besalazide. So what these will be composition andre 5-ASA plus sulfapyridine. So what this will do, this will help the ASA to reach distal colon and distal small intestine and colon, and thereby bring about the action, that is anti-inflammatory activity. Okay, so how does it what is the composition, what exactly does this sulfapyridine do andre? It is a carrier, it is linked by azo bond. Okay, so this delivers the 5-ASA moiety to the colon, but the disadvantage is whatever the side effects will be there because of this drug, that will be mainly due to sulfapyridine and not because of 5-ASA. But we'll always weigh the risk benefit, and compared to risk there is more benefits, so we are using this. Okay, so next one being 5-ASA plus 5-ASA, again this will do the same thing, and besalazide, that is 5-ASA plus 4-amino benzoyl beta alanine, these all act as carriers. So these three drugs are used as ASA agents now. Okay, so mainstay of treatment is ASA agents. Other than that, we can use antibiotics also. So antibiotics like metronidazole and ciprofloxacin can be used. So when is metronidazole used? Metronidazole is used in active inflammatory or fistulous or perianal Crohn's disease. Okay, so Crohn's disease, if there is active inflammation going on, or if there is an internal or external fistula, or if there is a perianal involvement in Crohn's disease, in that cases there will be increased chances of infections along with inflammation. So for inflammation we can give 5-ASA agents, and to treat this infection we will need antibiotics, and metronidazole is used in case of these three types of Crohn's disease. There is no role of active or quiescent ulcerative colitis. Okay, okay, metronidazole can also be used in patients of pouchitis. So we had discussed while discussing large intestine also. If entire large intestine is involved in ulceration, then what we'll do, we'll go for total proctocolectomy plus whatever is remaining ileum with anum, anal canal, is anastomosed. So ileal pouch anal anastomosis is done. So whatever this pouch is remaining, that can undergo inflammation as a complication, that is called as pouchitis. So in that case, again, along with pouchitis, there can be abscess also. So in order to prevent that abscess, we can go for antibiotic, that is metronidazole. Okay. Other antibiotic which we can use is Ciplox or ciprofloxacin, which is again used in active inflammatory fistulas or perianal Crohn's disease, and this is also used in cases of pouchitis. So either metronidazole or Ciplox can be used. Okay. So we can also use steroids in these cases, mainly glucocorticoids. It is used for induction of remission. So remission basically means disappearance or decrease, you can say, in signs and symptoms. Basically this term is used while referring to cancers. Remission of cancer andre ಮುಂಚೆ ಎಷ್ಟು ಸೈಜಲ್ಲಿ ಇತ್ತು, now it is reducing ಅಂತ. The remission of cancer has begun. Similarly, for inducing remission of ulcerative colitis and Crohn's disease, we can use steroids. So this will help in just reducing the signs and symptoms. After this, again we have to maintain this by giving certain other drugs. So for remission, glucocorticoids. For maintenance, there is some other drugs. So glucocorticoids has no role in maintenance. Okay. So agents used for inducing remission ಅಂತ ಕೇಳಿದರೆ these steroids will come there. So glucocorticoid, one we had discussed, other one being prednisolone, again a steroid. Then parenteral agents like hydrocortisone or methylprednisolone can be used, and budesonide can be used. So basically all steroids are remission inducing agents. So initially, in order to induce remission, we can use. After that, we have to use some other drugs for maintenance. Okay. So budesonide, it is released entirely in colon, so most commonly used, and it has minimal or no steroid side effects. So budesonide can be used because it will involve entire colon and it has minimal or no steroid side effects. Okay. So till now we have discussed 5 ASA agents, that is 5 amino salicylic agents. After that antibiotics, after that steroids or remission inducing agents, and now the fourth one being azathioprine or 6-mercaptopurine. These are basically used in management of steroid dependent IBD. Okay, and these are also used as maintenance therapy. So for induction, steroids are used. After that, azathioprine or 6-mercaptopurine, these are used as maintenance agents. These are also used in treating active perianal diseases and fistula in case of Crohn's disease. Okay, so basically I am just giving an overview of what all drugs can be used. Okay, after this we will study the combination, how exactly we will use for treating mild ulcerative colitis, mild Crohn's, moderate to severe ulcerative colitis, moderate to severe Crohn's. These are all will be discussed under separate headings. Okay, so next, fifth kind of drug being methotrexate. This is again effective in inducing remission and reducing steroid doses. So for inducing remission, we can use 2 drugs. One being steroids, other being methotrexate. Okay, this is effective in maintaining also. We had studied steroids, no role in maintenance. Okay, but methotrexate can induce as well as maintain. This is the difference. Okay, so next, 6th drug being cyclosporine. So this is again used in severe ulcerative colitis and wherever the disease is refractory to IV glucocorticoids. Okay, in that case we can use cyclosporine. Tacrolimus, again this has good efficacy in children with inflammatory bowel diseases. Children alli use ಮಾಡಬಹುದು tacrolimus, and in adults with extensive involvement of small intestine. Okay, budesonide colon alli, tacrolimus in small intestine. So effective in adults with steroid dependent or refractory ulcerative colitis and Crohn's disease and refractory fistulizing Crohn's disease. Okay, now coming to eighth type of drug, that is anti-TNF therapies, tumor necrosis factor basically. Okay, so this includes monoclonal antibodies. The first one being infliximab. MAB andre monoclonal antibody anta. So these are developed from one clone of cells, hence the name monoclonal. Aita, ಈ ಇದರಲ್ಲಿ ಯಾವ ಆ್ಯಂಟಿಜನ್ ಇನ್ವಾಲ್ವ್ ಆಗ್ತಿದೆ ಅದಕ್ಕೆ ತಕ್ಕಂಗೆ ಒಂದು ಆ್ಯಂಟಿಬಾಡಿ ಅಂದರೆ ಒಂದು ಸೆಲ್ ಟೈಪ್ನ ಯೂಸ್ ಮಾಡಿ ಅದನ್ನು ಕ್ಲೋನ್ ಮಾಡಿ ಅದಕ್ಕೆ ತಕ್ಕಂಗೆ ಆ್ಯಂಟಿಬಾಡಿ ಡೆವಲಪ್ ಮಾಡಿ ದೇ ಪ್ರಿಪೇರ್ ದಿಸ್ ಡ್ರಗ್. ಅದಕ್ಕೆ ಮೊನೋಕ್ಲೋನಲ್ ಆ್ಯಂಟಿಬಾಡೀಸ್ ಅಂತ ಕರೀತಾರೆ. ಸೊ ಇನ್ಫ್ಲಿಕ್ಸಿಮ್ಯಾಬ್ ಇಟ್ ಈಸ್ ಅ chimeric IgG1 antibody against TNF1. So TNF1 is used as an antigen. Tumor necrosis factor 1 is used as an antigen, and against that an antibody is developed which is a chimeric IgG1. Okay. So this is infliximab. What all it is used? It is used for active Crohn's disease, refractory to steroids, and 6-mercaptopurine or ASA. Okay. So ಇವಾಗ ಇಂಡ್ಯೂಸ್ ಮಾಡೋಕ್ಕೆ ಸ್ಟೆರಾಯ್ಡ್ಸ್ ಯೂಸ್ ಮಾಡ್ತಿದ್ವಿ, ಅಥವಾ ಮೇಂಟೆನೆನ್ಸ್ ಏಜೆಂಟ್ಸ್ ಲೈಕ್ 6-mercaptopurine ಆರ್ ASA. ಇದು ಯಾವುದಕ್ಕೂ ವರ್ಕ್ ಆಗ್ತಿಲ್ಲ ಅನ್ನೋ ಕೇಸಲ್ಲಿ ವಿ ವಿಲ್ ಹ್ಯಾವ್ ಟು ರೆಸಾರ್ಟ್ ಫಾರ್ ಮೊನೋಕ್ಲೋನಲ್ ಆ್ಯಂಟಿಬಾಡಿ, ಆ್ಯಂಡ್ ಒನ್ ಸಚ್ ಮೊನೋಕ್ಲೋನಲ್ ಆ್ಯಂಟಿಬಾಡಿ ಈಸ್ ಇನ್ಫ್ಲಿಕ್ಸಿಮ್ಯಾಬ್. ಇಟ್ ಈಸ್ ಆಲ್ಸೋ ಯೂಸ್ಡ್ ಇನ್ ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ವಿತ್ ರಿಫ್ರಾಕ್ಟರಿ ಪೆರಿಯನಲ್ ಆರ್ ಎಕ್ಸ್ಟರ್ನಲ್ ಫಿಸ್ಟುಲಾ ಅಥವಾ ಎಂಟ್ರೋಕೋಲಿಕ್ ಫಿಸ್ಟುಲಾ. ಓಕೆ. It is also approved for treatment of moderate to severely active ulcerative colitis. Okay. So next monoclonal antibody being adalimumab. So idraleno against TNF alpha. So TNF alpha is used as an antigen, and against that a humanized recombinant IgG1 monoclonal antibody is developed. Okay. So this is approved for treatment of moderate to severe Crohn's disease and moderate to severe ulcerative colitis. Okay. Next monoclonal antibody is sertalizumab pegol. It is a recombinant FAB antibody fragment against TNF alpha again. So TNF alpha is again used as an antigen, and recombinant FAB antibody fragment is developed. This is effective in clinical response in patients with active inflammatory Crohn's disease. Next one being golimumab. It is again against TNF alpha but human IgG1 antibody. Okay, this is applied for moderate to severe ulcerative colitis. Okay. So ಇದೆಲ್ಲ ಜಸ್ಟ್ ಎಷ್ಟಾಗುತ್ತೆ ಅಷ್ಟು ನೆನ್ಪಿಟ್ಕೊಳ್ಳಿ. ಅಗೇನ್ ವಿಲ್ ಡಿಸ್ಕಸ್ ಅ ಕಾಂಬಿನೇಷನ್, ದೆನ್ ವಿಲ್ ಕಮ್ ಟು ನೋ. ಓಕೆ. ಸೊ ನೆಕ್ಸ್ಟ್ ಆ್ಯಂಟಿ-ಇಂಟಗ್ರಿನ್ಸ್. ಸೊ ದಿಸ್ ಇಸ್ ನಟಾಲಿಜುಮ್ಯಾಬ್. ಇಟ್ ಈಸ್ ಅ ಅಗೇನ್ಸ್ಟ್ ಇಂಟಗ್ರಿನ್ಸ್ ಅಂತ ಹೇಳಿದ್ದಾರೆ, ಆ್ಯಂಟಿ-ಇಂಟಗ್ರಿನ್ಸ್. ಸೊ ಇಂಟಗ್ರಿನ್ಸ್ ಆರ್ ಯೂಸ್ಡ್ as antigens here. So alpha-4 integrins, using this as antigen, a recombinant humanized IgG4 antibody is developed. This is used for induction and maintenance therapy in case of Crohn's disease. Okay, and it is also used in treatment of refractory or intolerant to anti-TNF therapies. So anti-TNF therapy ಓದಿದ್ವಲ್ಲ ಇಲ್ಲಿ, ಇವಾಗ ಇಷ್ಟು ಏನು ಆ್ಯಂಟಿಬಾಡೀಸ್ ಓದಿದ್ದೀವಿ, ಲೈಕ್ ಇನ್ಫ್ಲಿಕ್ಸಿಮ್ಯಾಬ್, ಅಡಾಲಿಮುಮ್ಯಾಬ್, ಸರ್ಟೋಲಿಜುಮ್ಯಾಬ್, ಗೋಲಿಮುಮ್ಯಾಬ್, ಇವು ಯಾವುದಕ್ಕೂ ಟ್ರೀಟ್ಮೆಂಟ್ ವರ್ಕ್ ಆಗ್ತಿಲ್ಲ ಅಂದರೆ ನೆಕ್ಸ್ಟ್ ಚಾಯ್ಸ್ ಆ್ಯಂಟಿ-ಇಂಟಗ್ರಿನ್ಸ್, ದಟ್ ಈಸ್ ನಟಾಲಿಜುಮ್ಯಾಬ್ ಆರ್ ವಿಡೋಲಿಜುಮ್ಯಾಬ್. ಓಕೆ. ಸೊ ನೆಕ್ಸ್ಟ್ ವಿಡೋಲಿಜುಮ್ಯಾಬ್, ಇಟ್ ಈಸ್ ಅ monoclonal antibody against alpha-4 beta-7 integrins, indicated for patients with inadequate response to glucocorticoids or anti-TNF therapies or immunomodulators. Immunomodulators ಬಂದು ಸೈಕ್ಲೋಸ್ಪೋರಿನ್, ಟ್ಯಾಕ್ರೋಲಿಮಸ್ ಇವೆರಡು ಓದಿದ್ವಲ್ಲ, ದೀಸ್ ಆರ್ immunomodulators. ಸೊ ಇದುವರೆಗೂ ಓದಿದ್ರೆ ಯಾವ ಡ್ರಗ್ಸ್ ವರ್ಕ್ ಆಗ್ತಿಲ್ಲ ಅಂದರೆ ವಿಲ್ ಗೋ ಫಾರ್ ಇಂಟಗ್ರಿನ್ ಆ್ಯಂಟಾಗೋನಿಸ್ಟ್ಸ್ ಅಥವಾ ಆ್ಯಂಟಿ-ಇಂಟಗ್ರಿನ್ಸ್, ದಟ್ ಈಸ್ ನಟಾಲಿಜುಮ್ಯಾಬ್ ಆರ್ ವಿಡೋಲಿಜುಮ್ಯಾಬ್. ಓಕೆ. ಸೊ ದಿಸ್ ವಾಸ್ ಅಬೌಟ್ ಆಲ್ ದ ಡ್ರಗ್ಸ್ ವಿ ಆರ್ ಗೋಯಿಂಗ್ ಟು ಯೂಸ್. ನಾವು ಇನ್ ವಾಟ್ ಕಾಂಬಿನೇಷನ್, ಯಾವಾಗ ಯಾವ ಡ್ರಗ್ ಯೂಸ್ ಮಾಡಬೇಕು, ಇಷ್ಟು ಡ್ರಗ್ಸ್ ಇದೆ, 9 classes of drugs. So when we should use what kind of drugs, that is essential. For that we'll start discussing it in separate headings. Okay. Management of mild to moderate Crohn's disease. So mild to moderate Crohn's disease ಇದ್ದರೆ how we'll use. First obviously ಇವಾಗ ಸಪೋಸ್ ಇನ್ಫ್ಲಮೇಷನ್ ಇಷ್ಟಿದೆ ಅಂತ ಅಂದ್ಕೋಣ, ಫಸ್ಟ್ we have to reduce it. Okay. For that reason we will have to induce remission. For inducing remission we will go for usually budesonide for ileum and right colon, because budesonide ನಾನು ಹೇಳ್ದಂಗೆ ಯೂಶಲಿ ಇಟ್ ಈಸ್ ಸೆಕ್ರೆಟೆಡ್ ಇನ್ ಕೊಲಾನ್, ಎಂಟೈರ್ ಕೊಲಾನ್. ಸೊ ಕೊಲಾನಲ್ಲಿ ಏನಾದರೂ ಅಲ್ಸರ್ ಇದೆ ಅಂತ ಅಂದ್ಕೋಣ, ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ಈಸ್ ಅಫೆಕ್ಟಿಂಗ್ ಕೊಲಾನ್ or right colon, basically ascending colon or ileum, then we will induce remission by budesonide. After that for maintenance we will go for sulfasalazine. Okay. We have tried this treatment now, since it is mild, just one inducing agent and one maintenance agent. We tried this but it didn't work. There is no improvement in patient's symptoms. So what we will do, we will change the inducing agent now, that is prednisone. Okay, prednisone ಯೂಸ್ ಮಾಡ್ತೀವಿ. After that we'll use ಏನಂತಾರೆ, after that we'll use this azathioprine or 6-mercaptopurine or methotrexate. If the patient is steroid dependent, after using prednisolone, we'll go for 6-mercaptopurine or azathioprine. If it is active Crohn's disease, then we'll go for methotrexate. Okay, ಇವಾಗ ಇದನ್ನು ಟ್ರೈ ಮಾಡಿದ್ವಿ. ಈ ಕೇಸಲ್ಲಿ ಏನಾಯಿತು, ಇಫ್ ದ ಪೇಷಂಟ್ ಈಸ್ ರಿಫ್ರಾಕ್ಟರಿ ಟು ಅಜಾಥಯೋಪ್ರಿನ್ ಆರ್ 6-mercaptopurine, then we can't use this also. In that case, we'll go for anti-TNF therapy, that is monoclonal antibodies, infliximab, adalimumab, certolizumab, ಇಷ್ಟೋ ತನಕ ಓದಿದ್ವಲ್ಲ ಅದು. ಓಕೆ, ಸೊ ಬೇಸಿಕಲಿ ಒಂದು ಆರ್ಡರ್ ಫಾಲೋ ಮಾಡ್ತಿದ್ದೀವಿ. ಸ್ಟೆರಾಯ್ಡ್ಸು, ದೀಸ್ ಫಾರ್ ಇಂಡಕ್ಷನ್. ಓಕೆ, ಮೇಂಟೆನೆನ್ಸ್ಗೆ ಫಸ್ಟ್ 5 ASA ಏಜೆಂಟ್ಸ್ ಟ್ರೈ ಮಾಡ್ತಿದ್ದೀವಿ, ಸಲ್ಫಾಸಾಲಜಿನ್ ಈ ಥರದ್ದು. ಅದಕ್ಕೆ ವರ್ಕ್ ಆಗಲಿಲ್ಲ ಅಂದರೆ ಅಜಾಥಯೋಪ್ರಿನ್ ಆರ್ 6-mercaptopurine. ಇದಕ್ಕೂ ವರ್ಕ್ ಆಗಲಿಲ್ಲ ಅಂದರೆ anti-TNF. ಓಕೆ ಅಲ್ಲ. ಸ್ಟೆರಾಯ್ಡ್ಸಲ್ಲಿ ಇಂಡಕ್ಷನ್ಗೆ ಅದೇ ಬ್ಯೂಟಾಸೋನೈಡ್ ಯೂಸ್ ಮಾಡ್ತಿದ್ದೀವಿ, ಅದಕ್ಕೆ ವರ್ಕ್ ಆಗಲಿಲ್ಲ ಅಂದರೆ ಪ್ರೆಡ್ನಿಸೋನ್ ಯೂಸ್ ಮಾಡ್ತಿದ್ದೀವಿ. ದಿಸ್ ಈಸ್ ಫಾರ್ ಮೈಲ್ಡ್ ಟು ಮಾಡ್ರೇಟ್ ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್. ಓಕೆ, ಇವಾಗ ಮಾಡ್ರೇಟ್ ಟು ಸಿವಿಯರ್ ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ಇದ್ದರೆ ಏನು ಮಾಡಬೇಕು? ಮಾಡ್ರೇಟ್ ಟು ಸಿವಿಯರ್ ಇತ್ತಂದರೆ ಅಗೈನ್ ಇಂಡಕ್ಷನ್ ಏಜೆಂಟು ಶುಡ್ ಬಿ ಸ್ಟ್ರಾಂಗ್ ಫಸ್ಟೇ, because it is severe, inducing should be strong so that it will reduce to maximum smaller size. For that we will go for azathioprine, 6-mercaptopurine or methotrexate. So methotrexate, again now odidvalla, steroids or methotrexate, both can be used. Okay, azathioprine, 6-mercaptopurine or methotrexate. Along with that, in combination we will go for this anti-TNF. Okay, so first higher one we are using higher ones. Okay, after this, if again this is refractory, then we studied anti-integrins, that is natalizumab or vedolizumab. This is used for inducing remission. These are both inducing agents and maintaining agents, so for that reason they are using. For inducing remission, again glucocorticoids are used. After that, start total parenteral nutrition, that is patient will be having ulcers throughout, and after giving this we should not give him food, we should feed him through total parenteral nutrition. Okay, so this is the way. Like illi remission na first induce ಮಾಡ್ತಿಲ್ಲ in this case. In case of severe ulcerative chronitis, what we are doing is we are treating with maintenance agents, and then inducing remission we are using glucocorticoids IV, and then we are starting with total parenteral nutrition. Okay, first broad ಆಗಿ ಟ್ರೀಟ್ ಮಾಡಿ ಆಮೇಲೆ ನ್ಯಾರೋ ಆಗ್ತಾ ಇದ್ದೀವಿ. that is what the triangle is indicating. Okay, after this there is one more variety of Crohn's disease, that is fistulizing Crohn's disease. Okay, so in this case ಏನಾಗುತ್ತೆ, ಫಿಸ್ಟುಲಾ ಇದ್ದರೆ obviously there will be an abscess. we will have to go for incision and drainage of the abscess, and then we will go for antibiotics. Okay, antibiotics ಯಾವುದು, ಮೆಟ್ರೋನಿಡಾಜೋಲ್ or ಸಿಪ್ಲಾಕ್ಸ್. ಅಗೇನ್ ಆಫ್ಟರ್ ದಿಸ್ ಫಿಸ್ಟುಲಾ ಫಾರ್ಮೇಷನ್ ಆಗ್ತಿದೆ ಅಂದರೆ ಇಟ್ ಈಸ್ ಆಲ್ಮೋಸ್ಟ್ ಕನ್ಸಿಡರ್ಡ್ ಸಿವಿಯರ್ ಅಂತ. ಸೊ ವಿಲ್ ಗೋ ಫಾರ್ anti-TNF, that is infliximab, adalimumab or certolizumab for chronic disease with perianal or enterocolic fistula. This plus or minus azathioprine can be used if there is an active perianal disease with fistula in chronic disease or in Crohn's disease. Okay, if the patient is intolerant to 6-mercaptopurine, then we will go for anti-integrins. If still after using anti-TNF and anti-integrins there is no improvement, then at last we will go for total parenteral nutrition. Okay ala? Okay, so till now we have discussed mild to moderate Crohn's disease, moderate to severe Crohn's disease, and fistulizing Crohn's disease. After this we are starting with ulcerative colitis. Management of mild to moderate ulcerative colitis. So mainstay of therapy idralenu 5-aminosalicylic acid, oral or per rectal. Okay, ಇದಕ್ಕೆ ಇಂಪ್ರೂವ್ ಆಗಲಿಲ್ಲ ಅಂದರೆ we will go for remission, that is glucocorticoid. After that no improvement, first rectal ಕೊಟ್ಟು ನೋಡ್ತೀವಿ, ಅದಾದಮೇಲೆ ಓರಲ್ ಕೊಡ್ತೀವಿ. ಇನ್ನೂ ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಆಗಲಿಲ್ಲ ಅಂದರೆ ಮೇಂಟೆನೆನ್ಸ್ therapy in steroid dependent ulcerative colitis, that is go for again 6-mercaptopurine or azathioprine, and after that anti-TNF therapy, infliximab, adalimumab, golimumab ಈ ಥರದ್ದು. So here moderate ಏನು ಮೈಲ್ಡ್ ಟು ಮಾಡ್ರೇಟ್ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್ಗೆ ಇದನ್ನು ಫಾಲೋ ಮಾಡ್ತೀವಿ, ಮೇನ್ಲಿ ASA. ಅದಕ್ಕೆ ರೆಸ್ಪಾಂಡ್ ಆಗ್ತಿಲ್ಲ ಅಂದರೆ ದೆನ್ ಗೋ ಫಾರ್ ಸ್ಟೆರಾಯ್ಡ್ಸ್. ಆಫ್ಟರ್ ದ್ಯಾಟ್ ಗೋ ಫಾರ್ ಅಜಾಥಯೋಪ್ರಿನ್ ಆರ್ 6-mercaptopurine. ಇದಕ್ಕೂ ವರ್ಕ್ ಆಗಲಿಲ್ಲ ಅಂದರೆ anti-TNF. ಓಕೆ, ನೆಕ್ಸ್ಟ್ ಒನ್ ಬೀಯಿಂಗ್ ಮಾಡ್ರೇಟ್ ಟು ಸಿವಿಯರ್ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್. ಇದು ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ಅಂತ ಆಗಿದೆ. Okay, management of moderate to severe ulcerative colitis. First, inducing remission. So remission induce ಮಾಡೋಕ್ಕೆ we'll go for glucocorticoids, oral or glucocorticoids IV. Because it is moderate to severe, we'll go for oral or IV. Okay, in next to maintain ಮಾಡೋಕ್ಕೆ ಏನು ಮಾಡ್ತೀವಿ, we can use azathioprine, 6-mercaptopurine or infliximab plus infliximab. If this doesn't work, then go for obviously anti-TNF. If again this doesn't work, we'll go for immunomodulators, cyclosporine. This is used for severe ulcerative colitis refractory to steroids. Okay, after this we can use immunomodulator or we can go for anti-integrin. In case there is inadequate response to steroids, ಪೂರ್ತಿ ರಿಫ್ರಾಕ್ಟರಿ ಇದ್ದರೆ ವಿಲ್ ಗೋ ಫಾರ್ ಇಮ್ಯುನೋಮಾಡ್ಯುಲೇಟರ್. ಇಫ್ inadequate response is there, then we can go for anti-integrins. So this is the management of moderate to severe ulcerative colitis. Okay, ಸೊ ಇವಾಗ ಇದು ಮೆಡಿಕಲ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಆಯಿತು. ಓಕೆನಾ, ಮೆಡಿಕಲ್ ಮ್ಯಾನೇಜ್ಮೆಂಟಿಂದ ಕ್ಯೂರ್ ಆಗ್ತಿಲ್ಲ ಅಂದರೆ ವಿ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಸರ್ಜರಿ. ಸೊ ವಾಟ್ ಆರ್ ದ ಇಂಡಿಕೇಶನ್ಸ್, ವೆನ್ ವಿಲ್ ವಿ ಡೂ ಸರ್ಜರಿ ಇನ್ ಕೇಸ್ ಆಫ್ ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ಆ್ಯಂಡ್ ವೆನ್ ವಿಲ್ ವಿ ಡೂ ಸರ್ಜರಿ ಇನ್ ಕೇಸ್ ಆಫ್ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್? ವಾಟ್ ಆರ್ ದ ಇಂಡಿಕೇಶನ್ಸ್? Indications in small intestine, that is if there is a stricture and obstruction which is unresponsive to medical therapy, ಅಥವಾ ಮ್ಯಾಸಿವ್ ಹೆಮೊರೇಜ್. ಮೆಡಿಕಲ್ ಥೆರಪಿಯಿಂದ ಹೆಮೊರೇಜಿಂಗ್ ನಾವೇನು ಮಾಡ್ತಿಲ್ಲ, ವಿ ಆರ್ ಜಸ್ಟ್ ಟ್ರೀಟಿಂಗ್ ಫಾರ್ ಅಲ್ಸರ್ಸ್. ಇಫ್ ದೆರ್ ಈಸ್ ಅ ಮ್ಯಾಸಿವ್ ಹೆಮೊರೇಜ್, ದೆನ್ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಸರ್ಜರಿ. ದೆನ್ if there is a refractory fistula, even after treating for fistulizing Crohn's disease, if it is not getting healed, then we will have to go for surgery, fistulectomy ಏನಾರು ಮಾಡಬೇಕಾಗುತ್ತೆ. ಆಫ್ಟರ್ ದಟ್ ಅಗೇನ್ ಆಬ್ಸೆಸ್, ಇನ್ಸಿಷನ್ ಆ್ಯಂಡ್ ಡ್ರೈನೇಜ್, ಆಮೇಲೆ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಕೊಡ್ಬೋದು. ಬಟ್ if it is not possible to for incision and drainage, then we will have to go for surgery. Okay, indications in colon and rectum. ಸೊ ಕೋಲೋನ್ ಆ್ಯಂಡ್ ರೆಕ್ಟಮಲ್ಲಿ ಯಾವಾಗ ಸರ್ಜರಿ ಮಾಡ್ತೀವಿ ಅಂದರೆ ಇಫ್ ದರ್ ಇಸ್ ಅನ್ ಇಂಟ್ರಾಕ್ಟಬಲ್ ಡಿಸೀಸ್, ಏನು ಮಾಡಿದರೂ ಕ್ಯೂರೇ ಆಗ್ತಿಲ್ಲ, ಇಟ್ ಈಸ್ ಇಂಟ್ರಾಕ್ಟಬಲ್, ಆರ್ ಅ ಫಲ್ಮನೆಂಟ್ ಡಿಸೀಸ್, ಪೆರಿಯನಲ್ ಡಿಸೀಸ್ ಅನ್ರೆಸ್ಪಾನ್ಸಿವ್ ಟು ಮೆಡಿಕಲ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್, ಇಫ್ ದರ್ ಇಸ್ ಅ ರಿಫ್ರಾಕ್ಟರಿ ಫಿಸ್ಟುಲಾ ಅಗೇನ್, if there is colonic obstruction, cancer prophylaxis, colonic dysplasia or cancer. Okay, obstruction ಎರಡು ಕೇಸಲ್ಲೂ ಇಟ್ ಈಸ್ ಆನ್ ಇಂಡಿಕೇಶನ್, ಅಬ್ಸಲ್ಯೂಟ್ ಇಂಡಿಕೇಶನ್. ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆಯ್ತು ಅಂದರೆ ಇಮಿಡಿಯೇಟ್ಲಿ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಸರ್ಜಿಕಲ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್. ಅದರ್ ಕಂಡೀಷನ್ಸ್, ಇಫ್ ದರ್ ಇಸ್ ಅ ಫೇಲ್ಯೂರ್ ಆಫ್ ಮೆಡಿಕಲ್ ಟ್ರೀಟ್ಮೆಂಟ್, ದೆನ್ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಡೂ ಸರ್ಜರಿ. ಓಕೆ, ಇಂಡಿಕೇಶನ್ಸ್ ಆಫ್ ಸರ್ಜರಿ ಇನ್ ಕೇಸ್ ಆಫ್ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್, ಅಗೇನ್ ಇಂಟ್ರಾಕ್ಟಬಿಲಿಟಿ ಇಫ್ ಇಟ್ ಈಸ್ ನಾಟ್ ಹೀಲಿಂಗ್ ಆಫ್ಟರ್ ಮೆಡಿಕಲ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಆಲ್ಸೋ, if there is a cancer, or if there is massive hemorrhage, or if there is a toxic megacolon. In all these conditions we will have to go for surgery in case of ulcerative colitis. ಆಯಿತು, ಏನು ಸರ್ಜರಿ ಮಾಡ್ತೀವಿ ಹಂಗಾದ್ರೆ ಅಂದರೆ ಇನ್ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್ ವಿಲ್ ಡೂ ಟೋಟಲ್ proctocolectomy ಪ್ಲಸ್ ileal pouch anal anastomosis. ದಿಸ್ ಈಸ್ ದ ಡೆಫಿನೆಟಿವ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್. ಅದೇ ದಟ್ ಅಗೈನ್ ileal pouch anal anastomosis ಮಾಡೋದ್ರ ಬದಲು ವಿ ಕ್ಯಾನ್ ಜಸ್ಟ್ ಡೂ ಇಲಿಯಾಸ್ಟಮಿ, ಆರ್ ವಿ ಕ್ಯಾನ್ ಗೋ ಫಾರ್ ಕಾಂಟಿನೆಂಟಲ್ ileal reservoir, that is called cock pouch, or we can go for end ileostomy. It depends on the ಏನಂತಾರೆ ಡಿಸೀಸ್ ಎಷ್ಟು ಇನ್ವಾಲ್ವ್ ಆಗಿದೆ ಅಂತ. ಓಕೆ, ನೆಕ್ಸ್ಟ್ ಕಮಿಂಗ್ ಟು ಪ್ರಾಪರ್ ಸರ್ಜರಿ, ದಟ್ ಈಸ್ ಟೋಟಲ್ proctocolectomy ಪ್ಲಸ್ ileal pouch anal anastomosis. So just like the name suggests, total proctocolectomy, entire colon is being removed and rectum is being removed. Okay, after that ileum is remaining in the small intestine, that is connected directly to anal canal. So this is the definitive treatment in case of ulcerative colitis. This is usually preferred in younger patients with no rectal dysplasia. Procedure ಏನು ಮಾಡ್ತಾರೆ, some part of the ileum, whole colon and rectum are removed. Okay, whatever the ileum is remaining, ileal pouch, that is used to create a pouch. Okay, and then it is anastomosed with anus. So like this. ಸೊ ಇಲ್ಲಿ ತೋರಿಸಿದಾರಲ್ಲ ಇಲಿಯಲ್ ಪೌಚ್ ಹೆಂಗೆ ಕ್ರಿಯೇಟ್ ಮಾಡ್ತಿದ್ದಾರೆ ಅಂದರೆ they are cutting this middle part and then they are anastomosing it. This is like a pouch now. So illu opening create ಮಾಡಿ, there is a pouch, you can hold substances and then from here it is a pouch. Okay, so rectum, entire colon is removed and some part of the ileum is removed. That is called as total proctocolectomy. So this pouch can be of various shapes. Most common agi J shaped pouch. Okay, ಈ ಥರ ಇವೆರಡರ ಮಧ್ಯೆ ಸೂಚರ್ ಮಾಡಿಬಿಡೋದು. ಸೊ ಇವಾಗ ಏನಾಗುತ್ತೆ, ಇಟ್ ಆ್ಯಕ್ಟ್ಸ್ ಲೈಕ್ ಅ ಪೌಚ್, ಇಟ್ ಕ್ಯಾನ್ ಹೋಲ್ಡ್ ಸಬ್ಸ್ಟೆನ್ಸಸ್ ಆ್ಯಂಡ್ ದೆನ್ ಏನಲ್ ಕೆನಲ್ಗೆ ಸಿ ದ ಡೈರೆಕ್ಟ್ ಕನೆಕ್ಷನ್. ಸೊ ವಾಟ್ ಎವರ್ ದ ಫೀಸಸ್ ವಿಲ್ ಬಿ ದೇರ್, ದಟ್ ವಿಲ್ ಪಾಸ್ ಥ್ರೂ ಲೈಕ್ ದಿಸ್. ಓಕೆ, ದಿಸ್ ಈಸ್ ಅ ಜೆ ಶೇಪ್ಡ್ ಪೌಚ್. ಓಕೆ, ಅದು ಬಿಟ್ಟರೆ ಎಸ್ ಶೇಪ್ಡ್ ಪೌಚ್. ಸೊ ಇಲಿಯಮ್ ಲೈಕ್ ದಿಸ್ ಆ್ಯಂಡ್ ದಿಸ್ ಈಸ್ ಎಸ್ ಶೇಪ್ಡ್ ಪೌಚ್. ಅದರ್ ದೆನ್ ದಟ್ ಡಬ್ಲ್ಯೂ ಶೇಪ್ಡ್ ಪೌಚ್. ಮೋರ್ ಸೂಚರ್ಸ್ ಹಾಕಿದ್ರೆ ಡಬ್ಲ್ಯೂ ಶೇಪ್ಡ್ ಪೌಚ್ ಬರುತ್ತೆ ಅಷ್ಟೇ. So these are the ileal pouches, types of ileal pouches which are usually used, S, J and W. Okay, so ಇದರಿಂದ ಏನು ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಆಗುತ್ತೆ, ವಾಟ್ ಆರ್ ದ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಆಫ್ ದಿಸ್ ಟೋಟಲ್ proctocolectomy and ileal pouch anal anastomosis in case of ulcerative colitis? Most common being pouchitis, which we had discussed till now, that is inflammation of the pouch. ಈ pouch ಏನಾಗಿದೆ ಇದರಲ್ಲಿ ಇನ್ಫ್ಲಮೇಷನ್ ಆಗೋಕ್ಕೆ ಶುರು ಆದರೆ ಅಗೈನ್ ಇಟ್ ವಿಲ್ ಫಾಲೋ ದ ಪಾತ್ ಆಫ್ ulcerative colitis. So that is the most common complication. ಅದು ಬಿಟ್ಟರೆ ಅಗೈನ್ ದೇರ್ ಕ್ಯಾನ್ ಬಿ ಅ ಸ್ಮಾಲ್ ಬವಲ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಬಿಕಾಸ್ ಸ್ಮಾಲ್ ಬವಲ್ ಈಸ್ ಡೈರೆಕ್ಟ್ಲಿ ಕನೆಕ್ಟಿಂಗ್ ಟು ಏನಲ್ ಕೆನಾಲ್. ಅದು ಬಿಟ್ಟರೆ ಪೆಲ್ವಿಕ್ ಸೆಪ್ಸಿಸ್, ಅಗೈನ್ ಇನ್ಫೆಕ್ಷನ್ ಆಗ್ಬೋದು, ಪೌಚೈಟಿಸ್ ಆಗುತ್ತೆ, ಅದರಿಂದ ಆಬ್ಸೆಸ್ ಫಾರ್ಮೇಷನ್ ಆಗುತ್ತೆ, ಅದರಿಂದ ಸೆಪ್ಸಿಸ್ ಆಗುತ್ತೆ. ಇಲ್ಲ ಅನಾಸ್ಟಮೋಟಿಕ್ ಆ್ಯಂಡ್ ಪೌಚ್ ಸೂಚರ್ ಲೈನ್ ಲೀಕ್. ಸೊ ಇಲ್ಲಿ ಸೂಚರ್ ಮಾಡಿರೋದು ಇಫ್ ಇಟ್ ಈಸ್ ನಾಟ್ ಸ್ಟ್ರಾಂಗ್ ಇನಫ್ ದೇರ್ ಕ್ಯಾನ್ ಬಿ ಲೀಕ್ ಫ್ರಮ್ ಹಿಯರ್. ಆ್ಯಂಡ್ ಪೌಚ್ ವೆಜೈನಲ್ ಫಿಸ್ಟುಲಾ ಇನ್ ಕೇಸ್ ಆಫ್ ಫೀಮೇಲ್ಸ್. ಓಕೆ, ಸೊ ನಾವು ಮೋಸ್ಟ್ ಕಾಮನ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಆಫ್ಟರ್ total proctocolectomy and ileal pouch anal anastomosis in familial adenomatous polyposis patient is small bowel obstruction. Okay, surgical option for ulcerative colitis in patients with certain special situations, like if the patient is older patient and if the patient has fecal incontinence, then we'll just go for total proctocolectomy and end ileostomy. Instead of creating a pouch, we'll just do end ileostomy. Okay, that is whatever the ileum is remaining, end portion, that is brought in contact with outer abdominal wall. So illೊಂದು ಸ್ಟೋಮಾ ಕ್ರಿಯೇಟ್ ಮಾಡಿ ಏನು ಮಾಡ್ತಾರೆ, ಒಂದು ಬ್ಯಾಗ್ ಹಾಕ್ತಾರೆ. ವಾಟ್ ಎವರ್ ದ ಫೀಸಸ್ ಇಸ್ ದಟ್ ವಿಲ್ ಕಮ್ ಅಂಡ್ ಕಲೆಕ್ಟ್ ಇನ್ ದಿಸ್ ಬ್ಯಾಗ್. ದಿಸ್ ಕ್ಯಾನ್ ಬಿ ಡಿಸ್ಕಾರ್ಡೆಡ್. ಓಕೆ, ಸೊ ದಟ್ ಈಸ್ ವೈ ಇಟ್ ಇಸ್ ಕಾಲ್ಡ್ ಎಸ್ ಎಂಡ್ ಇಲಿಯೋಸ್ಟಮಿ. ಮೂರು ಟೈಪ್ ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಲ್ವ ಇಲಿಯೋಸ್ಟಮಿಯಲ್ಲಿ. ಆ್ಯಂಡ್ ವೈಲ್ ಡಿಸ್ಕಸಿಂಗ್ ವಿ ಹ್ಯಾಡ್ I had told also, like we'll use this in case of ulcerative colitis ಅಂತ. So that is end ileostomy, loop ileostomy or double barrel. So this is a type of end ileostomy which is used in case of ulcerative colitis in old patients and with fecal incontinence. Okay, patient with confirmed rectal dysplasia, that is rectum is also involved in this case. In that case, mucosectomy with hand sewn IPAA. Okay, next patient with significant debility ಅಂತ ಕೇಳಿದ್ರೆ total TAC with very low Hartmann closure and end ileostomy. ಇದೇನು ನನಗೂ ಗೊತ್ತಿಲ್ಲ. ಓಕೆ, ವಿಲ್ ಲೀವ್ ಇಟ್. ಓಕೆ, ನೆಕ್ಸ್ಟ್ ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ಸೊ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸಲ್ಲಿ ವಿ ಡಿಸ್ಕಸ್ಡ್, ದಟ್ ಈಸ್ ಟೋಟಲ್ proctocolectomy ಅಂಡ್ IPAA. ಓಕೆ, ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ಆಫ್ ಏನೋರೆಕ್ಟಮ್ ಇದ್ದರೆ ಏನು ಮಾಡ್ತೀವಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಅಂತ. ಸೊ ಯೂಶಲಿ ವಿ ಹ್ಯಾವ್ ಡಿಸ್ಕಸ್ಡ್ ಕ್ರಾನ್ಸ್ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಇನ್ ಇಲಿಯಮ್ and it is skip lesion. So in certain scenarios it can involve rectum and anal. ಅದಕ್ಕೆ ಇದನ್ನು ಸಪ್ರೇಟ್ ಸ್ಪೆಷಲಾಗಿ ಸ್ಟಡಿ ಮಾಡ್ತಿರೋದು. ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ಇನ್ ಕೇಸ್ ಆಫ್ ಏನೋರೆಕ್ಟಮ್ ಅಂತ. ಏನಲ್ ಮ್ಯಾನಿಫೆಸ್ಟೇಷನ್ಸ್ ಏನಿರುತ್ತೆ, ಯೂಶಲಿ ಏನಲ್ ಕೆನಾಲ್ ಇನ್ವಾಲ್ವ್ ಆದರೆ ಕ್ರಾನ್ಸ್ ಡಿಸೀಸಲ್ಲಿ ದೆರ್ ವಿಲ್ ಬಿ ಮೋಸ್ಟ್ ಡಿವಾಸ್ಟೇಟಿಂಗ್ ಫೀಚರ್ಸ್ ಆ್ಯಂಡ್ ಮೋಸ್ಟ್ ಪೇನ್ಫುಲ್. ಓಕೆ, ದೆರ್ ವಿಲ್ ಬಿ ಇನ್ಕಾಂಟಿನೆನ್ಸ್ ಅಥವಾ ಪೇಷಂಟ್ಸ್ ಥ್ರೆಟ್ ಟು ಪೇಷಂಟ್ಸ್ ಕಾಂಟಿನೆನ್ಸ್ ವಿಲ್ ಬಿ ದೇರ್. Okay, it occurs usually in 20% of the patients with Crohn's disease. Usually anal canal involved ಆದರೆ there will be ulceration, anal fistula or strictures, and this fistula can be cyanotic, chronic, indurated and painless. Okay. So what will be the clinical features if there is anal canal Crohn's disease? Then there will be anal fissure, fistula, abscess in the perianal region. Like we can see in this diagram, this is the anal canal and around that everything red, yellow, abscess, inflammation, fistula, ಏನು ಬೇಕಾದ್ರೂ ಆಗ್ಬೋದು. ಓಕೆ, ಸಿನ್ಸ್ ಇಟ್ ಈಸ್ ಅನ್ ಇನ್ಫ್ಲಮೇಟರಿ ಡಿಸೀಸ್, ಫಿಶರ್ಸ್ ಎಲ್ಲ ಆದರೆ ದೆರ್ ವಿಲ್ ಬಿ ಎಕ್ಸ್ಟ್ರೀಮ್ ಪೇನ್ ಆ್ಯಂಡ್ ಸ್ವೆಲ್ಲಿಂಗ್ ಆ್ಯಂಡ್ ಬ್ಲೀಡಿಂಗ್. ಓಕೆ, ದೆರ್ ಕ್ಯಾನ್ ಬಿ ಫ್ರ್ಯಾಂಕ್ ಇನ್ಕಾಂಟಿನೆನ್ಸ್ ಆಲ್ಸೋ. ಏನಲ್ಲಿ ಇನ್ಕಾಂಟಿನೆನ್ಸ್ ಆಯ್ತಂದರೆ ಈ ಕಾಂಟ್ hold the urge to defecate. Okay, he'll be just passing stools continuously. That is frank incontinence. And fever usually because inflammation is going on. There will be edematous and purplish tags. This is a characteristic feature in case of anal Crohn's disease. Okay, so evaluation, how will we go proceed with this patient? And we'll go for inspection and we'll see if there is active inflammation or active fissure or fistula ಏನಾದರೂ ಇದೆಯಾ ಅಂತ we'll go for inspection, and then we'll go for digital rectal examination, that is rectal examination. After that we can go for proctoscopy or proctosigmoidoscopy. So once we confirm it is a anorectal Crohn's disease, then we'll manage them usually conservatively. If surgery is performed, it will be performed for pain resulting from the undrained or poorly drained abscess. So basically incision and drainage ಮಾಡಬಹುದು in case if there is severe pain. Okay. If there is a fissure in case of Crohn's disease, then these fissures usually will not be single, it will be multiple, and it will be located off the midline. So in this case, if there is a Crohn's disease fissure, then we will avoid fissurectomy or lateral sphincterectomy because it will again cause incontinence. So we will avoid and we will try to treat it conservatively. Again, infliximab we discussed, that is used for treatment of fistulizing Crohn's disease. Fistula closure rate is 25 to 67% when infliximab, that is anti-TNF, is used. Okay. So what is the staged approach for perianal disease? In this case, the first step is to control the local sepsis. Okay, ಅದಕ್ಕೆ ಏನು ಮಾಡ್ತೀವಿ, we'll go for incision and drainage of the abscess and antibiotics. So fistula tract require chronic drainage with non-cutting seton. Okay, so basically we'll try to track that fistula and we will suture it or put some agent in that so that it will undergo fibrosis. After that, second step is using infliximab because it is used for treating fissuring Crohn's disease. So this should be given only after control of local sepsis, and after 2 to 3 infusions of infliximab, setons are removed, or whatever the gel type of packing which we do, that are removed for fistula closure. Okay, and the third step, if even after incision and drainage, control of sepsis and anti-TNF, if it is not curing, then we'll go for surgery. That is if fistula doesn't heal and local sepsis is resolved. In that case, we'll go for surgery. Okay, next, speaking with colitis associated with colon cancer. Colitis associated colon cancer. In this case, colitis associated colon cancer arises from flat dysplasia and dysplasia associated lesion or mass. It has multiple synchronous colon cancer in 12% cases. Okay, synchronous colon cancer, almost all cancers will arise at a same time. Synchronous. Mean age is about 30 years and distributed uniformly throughout the colon. Okay, these are mucinous or anaplastic variety is more common. In case of sporadic colon cancer, colitis associated idre colon cancer, you basically colon cancer ಬಗ್ಗೆ ಡಿಸ್ಕಸ್ ಮಾಡ್ತಿದ್ದೀವಿ. ಅದರಲ್ಲಿ colitis associated colon cancer ಈ ಫೀಚರ್ಸ್ ಇರುತ್ತೆ. If it is a sporadic colon cancer, it usually arises from adenomatous polyps. ನಾವೇನು ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಿ, FAP and HNPCC, hereditary non polyposis colorectal cancer, ಇದರಿಂದಾಗಿ ಅರೈಸ್ ಆಗಿದ್ರೆ ಇಟ್ ಈಸ್ ಅ ಸ್ಪೊರಾಡಿಕ್ ಕ್ಯಾನ್ಸರ್. ಇಫ್ ಫಸ್ಟ್ ಇನ್ಫ್ಲಮೇಷನ್ ಆಗಿ ಅದರಿಂದ ಕ್ಯಾನ್ಸರ್ ಆಗಿದ್ರೆ ದಟ್ ಈಸ್ ಕೊಲೈಟಿಸ್ ಅಸೋಸಿಯೇಟೆಡ್ ಕೊಲಾನ್ ಕ್ಯಾನ್ಸರ್. ಓಕೆ, so arises from the adenomatous polyps idre, that is sporadic colon cancer. It has multiple synchronous colon cancer again, but is seen in only 3 to 5% cases and usually old age alli 60 years, and it has left sided predominance. ಇಲ್ಲಿ ಥ್ರೂಔಟ್ ದ ಕೊಲಾನ್ ಯೂನಿಫಾರ್ಮ್ ಆಗಿರ್ತಿತ್ತು, ಬಟ್ ಹಿಯರ್ ಲೆಫ್ಟ್ ಸೈಡೆಡ್ ಅಂದರೆ ಡಿಸೈಡಿಂಗ್ ಕೊಲಾನ್ ಮೇನ್ಲಿ ಇನ್ವಾಲ್ವ್ಡ್. ಮ್ಯೂಸಿನಸ್ ಆರ್ ಅನಾಪ್ಲಾಸ್ಟಿಕ್ ವೆರೈಟಿನ ಇಲ್ಲೂ ಕಾಮನ್. ಓಕೆ, ಸೊ ರಿಸ್ಕ್ ಆಫ್ ಕೊಲೋನಿಕ್ ಕ್ಯಾನ್ಸರ್ ಅಂದರೆ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸು, ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ಎರಡರಲ್ಲೂ ಕೊಲೋನು ಸೇಮ್ ಆಯಿತಾ, ಎರಡರಲ್ಲೂ ರಿಸ್ಕ್ ಇದೆ, ಈಕ್ವಲ್ ರಿಸ್ಕ್. ಫಾರ್ ಸ್ಮಾಲ್ ಇಂಟೆಸ್ಟೈನ್ ಅಂದರೆ ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ವಿಲ್ ಬಿ ಮೋರ್ ಬಿಕಾಸ್ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್ ಯೂಶಲಿ ಸ್ಟಾರ್ಟ್ಸ್ ಫ್ರಮ್ ರೆಕ್ಟಮ್. ಸೊ ರೆಕ್ಟಮ್ ಫಸ್ಟ್ ಇರೋದ್ರಿಂದ ಕೊಲಾಂಜಿಯೋಕಾರ್ಸಿನೋಮಾ ಇದಕ್ಕೆಲ್ಲ ಅಗೇನ್ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್ ಬಿಕಾಸ್ ಲಿಂಫ್ಯಾಟಿಕ್. ಓಕೆ, more than Crohn's disease. Small intestine ge Crohn's disease is more than ulcerative colitis. Risk factors for cancer in ulcerative colitis ಕೇಳಿದರೆ it is duration of colitis, ಎಷ್ಟು ಡ್ಯೂರೇಷನ್ ಇಂದ ಇನ್ಫ್ಲಮೇಷನ್ ಆಫ್ ಕೊಲಾನ್ ಇದೆ, ಎಕ್ಸ್ಟೆಂಟ್ ಆಫ್ ದ ಕೊಲಾನಿಕ್ ಇನ್ವಾಲ್ವ್ಮೆಂಟ್, ಎಷ್ಟು ಕೊಲಾನ್ ಇನ್ವಾಲ್ವ್ ಆಗಿದೆ, ಪ್ರೆಸೆನ್ಸ್ ಆಫ್ ಪ್ರೈಮರಿ ಸ್ಕ್ಲಿರೋಸಿಂಗ್ ಕೊಲಾಜೈಟಿಸ್ ಆ್ಯಂಡ್ ಫ್ಯಾಮಿಲಿ ಹಿಸ್ಟ್ರಿ ಆಫ್ ಕೊಲೋರೆಕ್ಟಲ್ ಕ್ಯಾನ್ಸರ್, or pancolitis and diagnosed at young age. All these will decide if the patient of ulcerative colitis will develop colorectal cancer. So ulcerative colitis related colorectal cancers ಅಂತ ಕೇಳಿದರೆ these will be usually multicentric, evenly distributed throughout the colon, infiltrative, highly aggressive and poorly differentiated. Okay, there are no significant difference between sporadic and ulcerative. So sporadic ಏನು ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಿ ನಾವು, FAPR and HNPCC ಇಂದ ಡೆವಲಪ್ ಆಗೋದು, ಅದು ಮತ್ತು ulcerative colitis related colorectal cancer, these will be same. ಓಕೆ, ಇದೆಲ್ಲ MCQ oriented ಬೇಕಿಲ್ಲ. ಓಕೆ, ವಿಲ್ ಗೋ ಫಾರ್ ಟಾಕ್ಸಿಕ್ ಮೆಗಾಕೊಲೋನ್. ಓಕೆ, ಟಾಕ್ಸಿಕ್ ಮೆಗಾಕೊಲೋನ್ ಅಂದರೆ ಇಟ್ ಈಸ್ ಅ ಸೀರಿಯಸ್ ಲೈಫ್ ಥ್ರೆಟನಿಂಗ್ ಕಂಡೀಷನ್ ಆಫ್ ಇಂಟೆಸ್ಟೈನ್ಸ್. ಸೊ ಇದು ಏನಾಗುತ್ತೆ, ಇಟ್ ಅಕರ್ಸ್ ಇನ್ ಪೇಷಂಟ್ಸ್ ಆಫ್ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್ ಆರ್ ಕ್ರಾನ್ಸ್ ಡಿಸೀಸ್ ಆರ್ ಇನ್ಫೆಕ್ಷಸ್ ಕೊಲೈಟಿಸ್, ಯಾರಲ್ಲಿ ಬೇಕಾದ್ರೂ ಆಗ್ಬೋದು, ದಟ್ ಈಸ್ pseudomembranous colitis. So all these patients can develop a complication called as toxic megacolon. So just like the name suggests, it is megacolon. Colon has increased to such a large extent, that is massive dilatation of colon, which leads to necrotic thin walled colon causing perforation. So basically this colon, whatever is there, that is having lining and it has certain extent. Okay, whatever is the food is getting accumulated, that has distended this colon so much that it has become, the pressure over the wall is so much that the blood supply to this gets obstructed and it will go for necrosis. Because of this reason it is called as toxic megacolon. Okay, so this will undergo necrosis and then there will be perforation. Okay, so what are the investigations? How can we diagnose toxic megacolon andre on radiography? So since there is perforation, the air content will be accumulated. So on radiography, that is plain x-ray abdomen ಮಾಡಿಸಿದ್ರೆ there will be pneumatosis, presence of air in the bowel. So that is a sign of perforation. Hence plain x-ray abdomen is critical for diagnosis to follow up the course. Okay, then radiological findings, transverse colon diameter, if it is more than 6 cm, then it is toxic megacolon. Okay, and if there are multiple air fluid levels, then there is a perforation ಆಗಿದೆ ಅಂತ. Normal colonic hostrations, these will be absent or severely disturbed because everything is dilated like this. So normal colonic hostrations ಏನು ಇರಬೇಕಿತ್ತು, that is lost. Okay, organs and their diameter in megacolon. So usually cecum involve ಆಗಿದ್ರೆ, cecum is more than 12 centimeters, ascending colon is more than 8 centimeter, transverse colon is more than 6 centimeter, rectosigmoid involve ಆಗಿದ್ರೆ more than 6.5. ಸೊ ನಾವು ಯಾವುದನ್ನು ಮೆಜರ್ ಮಾಡ್ತಿದ್ದೀವಿ, ಬೇಸ್ಡ್ ಆನ್ ದ್ಯಾಟ್ ಇಫ್ ವಿ ಹ್ಯಾವ್ ಟು ಸೇ ದ್ಯಾಟ್ ದ ಪೇಷಂಟ್ ಹ್ಯಾಸ್ ಟಾಕ್ಸಿಕ್ ಮೆಗಾಕೊಲೋನ್, ದೀಸ್ ಮೆಜರ್ಮೆಂಟ್ಸ್ ಆರ್ ಯೂಸ್ಡ್. ಓಕೆ, ದಿಸ್ ಈಸ್ ನ್ಯೂಮಟೋಸಿಸ್, presence of air. Okay, this blackish thing, everything is air. So because of perforation there will be air in the diaphragm, air below the diaphragm, that is pneumatosis. After that, this is toxic megacolon ulcerative colitis ಇದರಲ್ಲಿ. So here we can see dilated one, and here also dilated, entirely dilated. There is no hostrations also, that we can say toxic megacolon. So how will we manage toxic megacolon? Basically medical management usually has high recurrence and urgent laparotomy should be required because perforation is an emergency. Okay, pre-operatively stabilization we can go for IV fluids and antibiotics, and treatment of choice bandu total abdominal colectomy with ileostomy. Preservation of rectum is done usually. Okay, so other complication of ulcerative colitis and Crohn's disease which we had discussed till now is pouchitis. Okay, that is the inflammation of the mucosa of ileal pouch, that is S, J or W, ಯಾವ ಶೇಪಿಂದಾದರೂ ಆಗಿರ್ಬೋದು. ಇನ್ಸಿಡೆನ್ಸ್ 7 to 33% ಕೇಸಸ್. ಎಟಿಯಾಲಜಿ ಏನಕ್ಕಾಗುತ್ತೆ ಈ ಪೌಚೈಟಿಸ್ ಅಂದರೆ ಗೊತ್ತಿಲ್ಲ. ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಡ್ಯೂ ಟು ಬ್ಯಾಕ್ಟೀರಿಯಲ್ ಓವರ್ ಗ್ರೋತ್ ಬಿಕಾಸ್ ಸ್ಮಾಲ್ ಇಂಟೆಸ್ಟೈನ್ ಹ್ಯಾಸ್ ನಾರ್ಮಲ್ ಗಟ್ ಫ್ಲೋರಾ. ಅದರ್ ದನ್ ದಟ್ ಮ್ಯೂಕೋಸಲ್ ಇಶ್ಯೂಮಿಯಿಂದ ಆಗಿರ್ಬೋದು, ಅಥವಾ ದೇರ್ ಕ್ಯಾನ್ ಬಿ ಸಮ್ ಲೋಕಲ್ ಫ್ಯಾಕ್ಟರ್ಸ್. ಓಕೆ, ಕ್ಲಿನಿಕಲ್ ಫೀಚರ್ಸ್ ಏನಾಗಿರುತ್ತೆ ಪೌಚೈಟಿಸ್ ಆದರೆ, ದರ್ ವಿಲ್ ಬಿ ಇನ್ಕ್ರೀಸ್ ಸ್ಟೂಲ್ ಫ್ರೀಕ್ವೆನ್ಸಿ, ದಟ್ ಈಸ್ ಡಯೇರಿಯಾ ಆಗ್ಬೋದು. ಡಯೇರಿಯಾ ಆದರೆ ಏನಾಗುತ್ತೆ, ದರ್ ವಿಲ್ ಬಿ ಲಾಸ್ ಆಫ್ ಫ್ಲೂಯಿಡ್ ಆ್ಯಂಡ್ ಎಲೆಕ್ಟ್ರೋಲೈಟ್ಸ್ ವಿಚ್ ವಿಲ್ ಲೀಡ್ ಟು ಡಿಹೈಡ್ರೇಷನ್. ಅದು ಬಿಟ್ಟರೆ ಬಿಕಾಸ್ ಆಫ್ ಇನ್ಫ್ಲಮೇಷನ್ ದರ್ ಕ್ಯಾನ್ ಬಿ ಫೀವರ್, ಆರ್ ಬಿಕಾಸ್ ಆಫ್ ದಿಸ್ ಇನ್ಫ್ಲಮೇಷನ್ ದರ್ ಕ್ಯಾನ್ ಬಿ ಬ್ಲೀಡಿಂಗ್ ಆ್ಯಂಡ್ ಕ್ರ್ಯಾಂಪ್ಸ್. ಓಕೆ, ಸೊ ಟ್ರೀಟ್ಮೆಂಟ್ ಏನು ಮಾಡ್ತೀವಿ, ಡಿಹೈಡ್ರೇಷನ್ ಆಗ್ತಿದೆ ರಿಹೈಡ್ರೇಷನ್ ಮಾಡ್ತೀವಿ. ಇನ್ಫೆಕ್ಷನ್ ಆಗೋ ಚಾನ್ಸಸ್ ಇರುತ್ತೆ, ಓರಲ್ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಕೊಡ್ತೀವಿ, ದಟ್ ಈಸ್ ಮೆಟ್ರೋನಿಡಾಜೋಲ್ ಆರ್ ಸಿಪ್ಲಾಕ್ಸ್. ಓಕೆ, ಪ್ರೋಬಯೋಟಿಕ್ಸ್ ಬಿಕಾಸ್ ಗಟ್ ಫ್ಲೋರಾ ಡ್ಯಾಮೇಜ್ ಆಗಿರ್ಬೋದು. ಫಾರ್ ದ್ಯಾಟ್ ರೀಸನ್ ವಿಲ್ ಹ್ಯಾವ್ ಟು and also we are giving antibiotics. For that reason we will have to improve the gut flora. For that reason we will give probiotics. Significant pouchitis which is not responding to this treatment, then we will have to go for Crohn's disease, and Crohn's disease should be considered and we have to evaluate it. Okay, so this was all about pouchitis. In general, now we are summarizing entire Crohn's disease and ulcerative colitis through this tabular column. Okay, so please pay attention here. Entire 2 classes we are going to summarize in this. First one being Crohn's disease. Macroscopically ಅಂದರೆ pathology gross ಆಗಿ ಏನಿತ್ತು, ಡಿಸ್ಟ್ರಿಬ್ಯೂಷನ್ ಹೆಂಗಿತ್ತು these ulcers, it was segmental with skip areas. ಕರೆಕ್ಟಾ? Usually it will start from ileum, then cecum and ascending colon is involved. Okay, extend the entire thickness of the bowel wall, hence it was called as transmural. Okay, ulcers usually serpiginous ulcers that may develop into deep ulcers. Usually surface ಅಲ್ಲಿ ಇರುತ್ತೆ, but it can undergo deep and it will involve entire 4 layers. Okay, pseudopolyps are rarely seen and fibrosis is common in case of Crohn's disease. Shortening of the bowel because of fibrosis is seen. In case of ulcerative colitis, it starts from rectum and it is continuous without skip areas. Okay, rectum ಆಮೇಲೆ ಅದರ ಮೇಲ್ಗಡೆ ಏನಿದೆ sigmoid, ಅದರ ಮೇಲ್ಗಡೆ colon, like descending colon, transverse colon, ascending colon. Extent usually superficial and confined only to mucosa and submucosa. Ulcers, superficial mucosal ulcers ಇರುತ್ತೆ. Pseudopolyps are commonly seen. Fibrosis rare because only superficial involve ಆಗ್ತಿದೆ, ಹಾಗೆ heal ಆಗ್ತಾ ಹೋಗುತ್ತೆ. Shortening usually ಆದರೆ because of contraction of the muscularis muscle. This was about gross features. Microscopically, histopathologically examine ಮಾಡಿದ್ರೆ ಏನು ಕಾಣಿಸುತ್ತೆ? Crohn's disease ಕೇಸಲ್ಲಿ depth of involvement inflammation ಅದೇ transmural, ಎಲ್ಲ layers of GIT is involved. Type of inflammation ನಾನು ಹೇಳ್ದಂಗೆ ನಾನ್ caseating granuloma. Caseating granuloma is seen in case of TB. Okay, ನಾನ್ caseating granuloma ಇರುತ್ತೆ and there will be inflammatory infiltrate of mononuclear cells. In case of ulcerative, ಇದು Crohn's disease, ಇದು ulcerative colitis. Ulcerative colitis ಅಲ್ಲಿ depth of inflammation only mucosa and submucosa ಗೆ ಲಿಮಿಟ್ ಆಗಿರುತ್ತೆ. Type of inflammation usually it is non-specific, acute and chronic inflammatory cells. Okay, mucosal changes. What will be the mucosal changes in case of Crohn's disease? There will be only patchy ulceration, but in case of ulcerative colitis there will be hemorrhagic mucosa with ulceration. Fine mucosal granularity was seen anta ಓದಿದ್ವಿ. There is hemorrhagic mucosa with ulcerations. Okay, submucosa, this was about mucosa. Submucosa widened due to edema and lymphoid aggregates. We all know lymphatic tissue is present in submucosa in case of GIT. Okay, so because of that reason there will be lymphoid aggregates and edema will be there. Here submucosa usually will be normal, reduced in width. Okay, muscularis is infiltrated by inflammatory cells, that is mononuclear cells. Here muscularis and rest every serosa, nothing is involved. Fibrosis is present in case of Crohn's disease because of transmural involvement. Here fibrosis is absent. Okay, what are the complications now? Complications, we all know if Crohn's disease involves anal region, then there can be fistula, fissure or anything. That fistula can be internal fistula and external fistula. Internal fistula we had discussed a lot, like if this is a bowel, then there can be abnormal connection here, that is internal fistula. Okay, in case of ulcerative colitis, fistula formation is rare. So malignant changes, in case of colon both are equal. Small intestine andre Crohn's is more than ulcerative colitis. In case of cholangiocarcinoma it is reverse, ulcerative colitis more than Crohn's. Fibrotic strictures are more common in Crohn's disease and fibrotic strictures are less common in ulcerative colitis. Toxic megacolon usually seen in case of ulcerative colitis more commonly. Okay, named features, whatever we had discussed in investigations, that can be string of Cantor sign or hose pipe or garden pipe or creeping fat pad sign, comb sign, raspberry thorn appearance, fat halo sign. Okay, basically ಎಲ್ಲ ಹೊಸ್ಟ್ರೇಷನ್ಸ್ ಹೋಗಿ it will be smooth like a pipe, garden hose pipe. That is why it is called as hose pipe appearance. Okay, so illunu there can be same garden hose appearance, pipe stem colon, lead pipe sign, stove pipe or collar button ulcers. So these are the features, named features seen in case of ulcerative colitis and Crohn's disease. So this brings us to the end of inflammatory bowel diseases. ಏನಾದ್ರು ಡೌಟ್ ಇದೆಯಾ?